All right. So I'm Sarah Sinclair. I am the executive director of the BC Rural Center, and it is a new role for me as of 2024. And my word for 2024 is I'm going to go with joy, that we're going to look for the joy in all the places. And I'm really excited to be here with everyone on this call. And I'm going to pass it to Naomi. Oops. I was breaking up. I'm sorry.
My name's Naomi Larson. I'm the executive director of the Chetwynd Chamber of Commerce up here in Chetwynd, BC. My word. The first word I think, and the first word that came to mind was feral. And feral in the sense of now when I find stuff that I want to get to the bottom of, or I want to do more of, or do anything, I'm just going to go for it. Just go all in and go do it. Just totally be feral about it. You want me to pick a new person?
Yeah, that'd be great. Thank you.
I'll pass it on to Bridget because she's right next to me on my screen.
Hello, everyone. Bridget Bettler. So I'm the project lead innovation and informatics for the RCCBC and supporting their rural personal health record project. I am from the Wet'suwet'en territory, which is also Smithers. And my word is frozen right now. Hopefully I'll change that word, but it's so cold in Smithers and we haven't had enough snow that our creek froze solid and we have no water source. So yeah, hopefully it warms up. I worry when we don't get enough snow, the animals, the impacts to gardens, everything, so hopefully it warms up when we get a little bit of snow. And I've been up here 34 years and I'm from Newfoundland originally, which should be a warning label. So
thank you.
I'll pass it over to Anton.
Good afternoon, everyone. Anton Meyer. I'm grateful to join you from the traditional unceded territory of the Silix people in Lake Country. And the word that's in my mind is grateful. Grateful to have this conversation. Grateful to be able to try to live the value of patient-centered and family-centered care and making sure our patients receive what they've always been neglected about, and that is have access in a meaningful way and contribute to their electronic health record information to create the safety that is so important. So I'm the project sponsor with Ray Martin on this project. And on behalf of RCC, it is our great blessing to join you in this conversation, and hopefully through this dialogue, we can enrich each other's experience and make this what it's supposed to be. Thank you for your time. I'll hand over to Ray.
Thanks, Anton. Hi, everyone. So Ray Markham, I'm a rural GP in the village of Valmont, usually on Calculated Land, some territory, but I am in foreign territory for me, so Coast Salish territory here in Vancouver. And that leads to my word for the day, which is U-turn. It is the most amazing thing that I saw when I was walking over Granville Bridge, which is somebody doing a U-turn on Granville Bridge. Only made possible because of the construction. I never thought I would ever see that, so I just wanted to share that amazing sight that I saw in the wilderness that is Vancouver. And I'm going to pass on to Tony.
Hi all, my name is Tony Shea. I hope you can hear me okay. I work for Siemens Healthineers in business development for a branch of our company called Enterprise Services. I'm traditionally based in Winnipeg, but today I'm in Toronto for the next few days. My word for the year, well, just generally speaking, is compassion. I believe we need a lot more of it in the world, and I think being involved in work that demonstrates our compassion for others is critical to my own mental well-being and to that of the folks around me. So compassion is my word. My goal in participating in this group, and I'm very honored to be here, thank you for inviting me and including me, is to understand how Siemens and what we stand for and what we say we stand for might fit well with the work that's being done by groups like RCCBC in others across the country. So that's my reason for participating. So thanks very much. And I'll pass it on to Bill.
Okay, thanks, Tony. Yeah, I'm coming to you from the territories of the Lake-Wita people, the Wee-Way-Kum and the Wee-Way-Kai First Nations in Campbell River on the West Coast. I'm formerly a full-service physician, family physician for many years in various places. I can say I trained in Newfoundland and I did my residency in Winnipeg, so already I can feel the connections. I also have had a long-standing interest in health informatics and using digital health for the benefit of not only healthcare, but just health. So the word, it's funny that you should ask for a word, because the word I was going to use in my opening remarks about the personal health record is kintsugi. Anybody here know what kintsugi is? All right, and Nicole knows. It's a Japanese term that really kind of originates with mending, the notion of mending, but it's the thing that puts broken things together in an art form, which you may have seen on TV as in an advertisement about investing in gold. Because they used to use gold to knit broken ceramics. And what we're about to talk to today, it struck me just before the meeting, is that we're actually, this whole PHR project is an exercise in kintsugi. And that what we're doing is knitting together pieces of the health system and health. When I say health, I mean health, not just care, right? Wellness being a key part of it. So that's a word that I'm going to reflect on quite a bit as I progress through this year, because I think it applies in all kinds of areas with interoperability and the kinds of stuff that I do. I'll pass it over to Nicole.
Oh, I'm not muted for a change. Okay, that's a hard act to follow. That's a great word. I love it because it's actually beautiful when you see the pieces that have been done. It's not broken, it's mended, but it becomes more beautiful after than it was when it started. So it's pretty cool. Yeah, so Nicole Liebert, I was a family doc up in Vanderhoof for a long time, and I'm now relocated to somewhere that looks exactly the same right now because it's snowing, to Coldstream, the traditional territories of the Silks people just up the road from Anton. And I'm one of the physician group lead people in this group for PHR, just trying to bring the rural physician perspective as well. And my word, hadn't thought about it ahead of time, but exploration, I suppose, is what came to mind. We have a million projects on the go, and there's so many new skills to learn and explore, and just being open to not being good at them, but figuring them out as we go. And I will pass to Pablita.
Hi, everyone. Pablita Thomas. I'm the CEO over at the BC Hospice and Palliative Care Association. We are a provincial and territorial organization that supports education, training, and advocacy to clinicians, the public, and the hospice and palliative care sector in both the territory and the province. I'm from the island. I live in Esquimalt. So I actually live on the Songhe First Nations. That's where we get to enjoy my children. And I'm saying my children because the word that I initially had was sleep, because I haven't slept in a while, because my youngest is still wanting to do that whole cuddling after going back to school. And I don't know what, she goes to the same school, but I don't understand. But the word for the year that really I find ever more so evident in the work that I've been doing since coming back into work is trust. You know, I feel a trust in all capacity, trust in partnerships, trust in community, but very much more so trust in policy and funders. You know, it is an election year, so I don't know how far that would go, but I find that when we're working with grant funders and the government, there's a lack of trust on the way that funding is administered in our province. Certainly when it comes to hospice and hospices that are in the rural regions, It's funders have a lot to learn about trust and allocating funding and programs and policies that reflect that. So I think this year, a lot of the work that we're going to do is building partnerships, but building them based on trust, for sure. Thank you. So I'm going to go to, who have I not seen before? Kathleen?
Hi, good afternoon, everyone. My name is Kathleen Chenor, and I'm the CEO of the Institute for Health System Transformation and Sustainability, and co-chair for the Link Partnership Table. I generally reside in Kamloops, in the traditional territory that is Tissaquak peoples. I am someplace warm. Bridget, I'm sorry, I didn't want to say that out loud. I got tired of being cold in the place where I normally reside and went someplace else. So things are a little bit better here. It's 28 degrees and sunny. I think the word for me for 2024 is balance. And I think balance not only for myself, but for those people around us. It's important that we maintain balances in our lives. And I think sometimes working in healthcare, we don't always do a very good job of maintaining the right balances and also supporting each other to maintain those right balances. I think it's taken me a long time. I've been in healthcare for 40 years. It's taken me a long time to realize just exactly how important balance is. And now I'm going down that impossible road of trying to see how I can maintain, that work hard, play hard. I'm great with all of that, but definitely needing to make sure that we all stay balanced in these very busy, challenging times. I am going to pass it over to Lorraine.
Hi, everyone. Lorraine Gerwing, Regional Counselor, third term. I don't have much of a voice today, and I also have a very slow internet connection, so I will be turning my camera off when I have to. So I reside in Fort Nelson, so the Northern Rockies Regional Municipality, which is traditional territory of Fort Nelson First Nation and Prophet River First Nation. Every year I pick a quote, and put that up on my whiteboard, and then I refer to that when I need it. And this year's quote is strength in the silence. So if I had to pick one word today, it would be strength. Yeah, did I miss anything? Nope, that's good. That's me, thanks. Oh, sorry, I have to pick somebody. Have we heard from Grace?
No, you haven't, but I'm happy to join in. I Grace McGregor. I've been elected at Christina Lake for 19 years. I was also involved with UBCM and represented all electoral area directors across the province. I have a passion for rural BC that we need to work together on. My word has constantly in front of me is change. And I choose that word because people are having so much trouble accepting change and trying to adapt to it. The warmth of our lake, for instance, all of those things that matter to every one of us. And we have to be working together, I believe, in order to make change a priority, not just with health, but just about everything we're dealing with these days. So thank you for asking me. I appreciate that.
And I think lastly is Luella and Allison are the two.
Yeah.
Left to go. So you guys I'll say Allison, and then Allison, you can pick the last one.
Good afternoon, everyone. I'm Allison James, and I work at the Rural Coordination Center of BC, and most of you are familiar faces to me, and I'm calling in from the unceded traditional territory of the Comox First Nation on Vancouver Island. And so, we don't have those huge cold temperatures. So I can feel for Bridget being up north and the cold temperatures there. Bridget, I am also from Newfoundland. you didn't know we had that in common. And in fact, we have not met before, and we both work with our CCBC, but in slightly different capacities. My word, and I set this word on December 21st when I went to a community winter solstice event, as I put a little candle on a kind of a little pyre thing, which was really neat, was curiosity. And just curiosity in work, curiosity in my relationships. Yeah, and that one really does stick to mind, because sometimes we can easily make assumptions, and if we just put a little bit more of a curious of what if, I wonder if, I wonder how, that the world is a little bit different with that mindset. And I will pass to Luella.
Well, you're on mute if you're speaking.
We've asked her to unmute. Maybe she is unable to, maybe she's multitasking, and she will introduce herself at a later time in the call. With that said, I will go ahead and share my screen for the slides that Bridget sent over. And I may have to turn my camera off if my internet decides that it doesn't like the snow and wants to be slow. So I'll share my screen, make sure everyone can see it okay. And then we'll have Bridget introduce the panelists, and Kathleen and I, as Kathleen is my strong co-host there, surviving in the hot temperatures in the south, that we'll manage the Q&A at the end of the call, and or at the end of the presentation. And Bridget, just let us know when you want. Can everyone see my screen okay?
Yeah, we can. Thank you so much.
And go ahead. Thank you.
Sorry, we weren't sure we're going to get Dr. Meyer today. So be patient with us as we do a little bit of a dog and pony show here. But Anton, would it be okay if I asked you to just kick us off here, and then you can wrap us up too at the end? That'd be lovely.
Sounds great. Thank you, Bridget. This is a deeply meaningful conversation for us. And as I said, we are grateful to have dialogue at this level with people that is close to us, or that we feel close to us. All of us have expressed through the words that we used and the background that we come from that rural is incredibly important to us. From the RCCBC point of view, now about 2 years ago, when we presented this opportunity to the Ministry of Health through the collaborative committees, the Joint Standing Committee on Rural, as physicians, we felt that it was important to begin this journey to try to get patients and the holistic team involved in addressing the problem that patients and families do not have access to their electronic health information, period. It's 2 years later than 2 years ago, and 200 years late for coming to this party where the world is beginning to show us through literature that when a patient joins us on this journey of self-care and having access to their information, that it begin to address many, many things. The longitudinal attachment to a patient medical home, that journey over time that has been proven without a shadow of a doubt to change the trajectory of disease, the outcome of disease, save lives, prevent illness, and also address disparity among disadvantaged populations. Beyond that, there are many efforts currently within the system to so-called allow a patient access to information. That access is focusing mainly on portal-style information sharing. You can have a unilateral lens, and you can see fragments and snippets depending on what is available on your record system in different places in health authorities and through the BC record. Health Gateway, you can have snippets of your information. We believe something different. We believe it is important that the patient leads us in that journey. Make sure that the patient understands the dynamics within the system. For a provider, it is not so simple and easy to be part of such a process to start the PHR. There is hesitancy, there is trepidation, there is fear. Is this going to overburden my world even more so than it does? This journey has been an humbling one for us, one that has given us the courage to become stronger and stronger, to be a voice on the science etching lead of this process, to tell your story to patients after we listen, to you as link sector partners, to academia, to our colleagues, to the funder of the system, the Ministry of Health, and to academia. We have taken strength more and more every step of the way. And we are so grateful to be able to share our story with you. I will hand over to Bill to begin to tell you a little bit more of what we do and how we try to do this. Bill?
Okay, thanks, Anton. Yeah, you can probably move down to the next slide, but you could see there that we have a number of partners, and there's more involved than just those that you're seeing here on the screen in this project. But we always welcome an opportunity to discuss this topic, because all of us, or most of us anyway, transition through being a patient, being a caregiver, caregiver who needs sleep. We heard already in this call, some of us are providers and are faced with all kinds of issues that the coal face. And we've been deeply informed by conversations with people in all of these different roles about what is needed for managing your health. So it's sort of a kind of an approach. If you think of the citizen as being like a business enterprise, there are certain things that just need to happen. Information, access to information, as it turns out, is just one of the pieces. There's so much more about interacting with the care team and so on and so forth, which all translates back to like the primary care value proposition itself, which includes things like longitudinal relationship, longitudinal continuity of the record, care coordination, navigation, accessibility, being adaptable to the socioeconomic determinants of health, fostering trust. I love it, actually. A lot of these points in that value proposition were expressed as the word here earlier. And of course, being culturally sensitive. And when you think of each one of those items in the value proposition of primary care, which bleed over into the value proposition of healthcare in general, there's so much that so much benefit that a patient can derive from having a personal health record, more than just the access to the information that it provides. So the next slide, please. Slide 4, I guess. So to look at this, we have taken really actually a community up approach from the grassroots, you might call it, but also a top-down approach. And top-down meaning interacting with folks such as yourself on this call, who are working towards better systems, better integration of services, various different kinds of services. And being informed from both ends helps us address the real issues of the coalface, while being aware of what the possibilities are that go beyond just what seems to be the obvious. So at the beginning, personal health records were primarily conceived of as a place to get information, because after all, it's a health record. And very successful projects like Open Notes in the US and globally prove beyond a shadow of a doubt that having access to that information is very, very helpful. But as the journey of personal health records over the last decade has evolved, it's also become apparent that its access to information is extremely useful and necessary, but insufficient. There's more that is needed. And like the ability to interact and integrate with the care team is vital to be able to access care in a seamless way. We take it for granted now that we can book a rental car in Europe in a hotel and do that all online. It's all seamless and easy. We can even interact with our banks. In fact, how many here physically visited a bank in the last 4 years since the pandemic started, right? So there's all of those functions that are vital as well. And then if you think of yourself as the manager of your health, you've got responsibilities like your wellness and what kinds of things are you due for, as it were. You also may have an interest in knowing whether or not your record is actually complete. So one of our patient representatives, who has a distant background as a medical practitioner, took it upon herself to go and ask for her problem list from her primary care physician. Now that apparently was a bit of a journey into itself, but she got her problem list, and she's older. I say that lovingly because I think she may be younger than me, but that's worrisome. And found that she knows she has 17 significant health concerns, not many of them very serious, but still significant. And her problem list only had 9. So having more eyes on the record and the ability to be able to interact with that record and actually provide contributions to it, like your housing status, like your education level, like your race, ethnicity, and gender identity, and things like that, to make the citizen or the patient a better part of the team, be able to fully participate as a team member. And so this is what made me think of that term kitsugi, because all of these elements that I've just described here right now are very challenging for a citizen in the world to navigate unless there is some assistance. And the personal health record is a tremendous way to approach this. So we'll get a little bit more into detail with that, but if we move to the next slide, Nicole will talk to you more about the value proposition and some tangible, real use cases. Go ahead, Nicole.
Thanks. It's almost overwhelming trying to figure out where to start because there's so many examples to bring in that. So I'm just going to pick a few. There's lots more. You've all lived them, heard them, had family members live them. And I think the scariest thing when we started this was for years, is recognizing that no one has all the information. And that's not the assumption that most patients have. They assume when they go to a physician or to interact with the health system that their health information will be there and people have access to it. And it's just not the case. And those big gaps in that data are scary. They're scary for patients and they're scary for providers. So and the gaps really are illustrated for people with health conditions or acute things that come up where you're bouncing from specialist to the hospital to the emergency department. And those transitions, your information doesn't flow with you. So that leads to duplication. You may tell your story 10 times. It's written down incorrectly a number of those times. You get duplications of labs because people can't find the labs you had just had done last week. When you travel from rural and you're traveling to specialists in the city, they might not have your consult letter, so you don't know why they're there. Or you don't know why you're there, they don't know why you're there. And all of those things lead to just a difficult journey. One of the patients said when we were going through this process, I'm the only person at every interaction with the health system, and I have the least amount of information and the least amount of control. So when we look at the PHR for patients and providers as a team, it's not just, I sort of said the health system just in my head as we were talking, feels like a puzzle where all of the information out there is a puzzle piece. and we can access that puzzle piece, but we actually don't have the picture. So when everything clicks together, it's kind of an accident or just lucky. So what the personal health record does could give you the picture for that puzzle. It lets you, but also lets it done in an integrative fashion. So as a patient, say I'm going through a cancer journey, and I go to the oncologist, and then I go to the lab, and then I go to my family doc. But I don't know what the oncologist said to my family doc, so I'm not sure what my plan is going to be. I don't know when I'm supposed to make another appointment. Are they supposed to contact me for another appointment? Am I supposed to be in charge of the lab work? And the family physician struggles sometimes too, because they're trying to put all of this information they get from the oncologist in their chart and make sure it's up to date, it's accurate, and it's difficult. It's overwhelming when you've got hundreds of these coming into your office every day. So what that PHR allows us is the patients then, if in an ideal world, the care plan is they can see what's supposed to happen. The family doc can see what's supposed to happen. The oncologist can be part of that team. All the allied health can be part of that team, and people are on the same page. So right now, the way that happens is we tell people to photocopy and print out every single interaction with the system and put it in their binder, which feels archaic in this day and age. So I think, when you talk to providers sometimes about the concept of a PHR, it's a little bit scary and it feels a bit overwhelming, because one of the thoughts was, am I going to have 200 messages waiting in my inbox when I get to the office in the morning? How am I going to manage that when I'm already up, I'm already full? But I think part of the discussion is, how do we, it's a complex system, and we have the ability to do things in a small amount of time. We have the ability to choose. Not everybody's going to want a message, but we will have the option to talk to people who really need it in real time. So say I have a palliative care patient, then I have the ability to message that patient. That patient can message back into the system. It arrives into their chart. It's not lost on my phone, and it's just connected and safer. So as I say, there's a million examples. Medications, don't even let me start it, because that's probably the scariest and the most difficult thing to keep accurate. But there's so many ways that I think the PHR will just improve that whole team ability to support patients as they go through all their journeys. And I'm going to stop there because it just gets messy. So, and I'm not sure who's next.
I'll pick it up from there.
Thanks, Bill.
Thanks for setting the ball perfectly on the net. Actually, if you could just advance to the next slide, please, the Greg Zwings thing. Because much of what was in that slide, if you want to look at it later, is helpful, but Nicole addressed most of that. If you haven't seen Greg Zwings, it's really worth a viewing if you really want to get down and dirty about what the issues are that we're talking about, including Naomi's entry here about the frustration of being flown out to a rural area. Greg's Wings is about if you haven't seen it, a man around his 30s, I can't remember exactly his age, a farmer on the prairies, who through a series of sequential medical errors and misadventures in the system, not with individuals per se, but system generated issues, died because unnecessarily from a condition which is mostly treatable. It is a cancer, but if caught early, is mostly totally curable. So the family took up the cause to expose this issue not in a bid to be blaming to anybody, but rather to sort of encourage system change. So it is worth looking at if you haven't seen it, and I think you can still get it on YouTube and other sources. So the next slide, please. So I think the really important component of our message here is about the PHR as an integrator. So from all different sources, because even the patient armed with the binder, as Nicole so nicely described, because actually even the chief operating officer of the Northern Interior and Northern Health was forced to carry a binder around as he managed his parents' health. It was like just sad to have to do that to get the data. But so if we had a system of portals for everybody, like every consultant had a portal and every health authority had a portal and the ministry has the health gateway and primary care and so on, you would be farther ahead, but you would still have to go to all these different places to get everything. And like the blind man and the elephant, you wouldn't be able to connect stuff. And unlike the blind man and the elephant, where you could still tug on the trunk, you can't really interact with it. You just look at it. Okay, so now what does that mean? And that's actually what the people with lots of experience with portals, like New Zealand, coined the term a front door to nowhere, a digital front door to nowhere, for describing a portal where you have information, but you can't really easily message those who you need to message. You can't add anything. You might be able to make an appointment with that portal, but how do you get in touch with your consultant? And you have no idea, as like in Greg's Wings, who that consultant might actually be. So that's where I think it's really important to recognize the PHR and portal are distinct things, and it's not like we're saying that portals are bad. They're probably inevitably going to be still a part of the fabric of healthcare. There's some use cases for it, especially for people without too many medical problems who may choose to use that methodology of getting access to their information, which isn't too complex, and making, say, appointments with a health authority imaging facility, for example. So the idea that we're trying to get across, because to build this correctly, and that's where I was talking about the top-down type of thinking, with knowledge about health information standards and how the global system has responded to these kinds of issues. We are not talking about, okay, we're going to do some special things for PHRs to enable this. The standards and the technology that is required in order to facilitate this are exactly the same standards that are required to be interoperable across healthcare systems, like EMR to EMR communication or receiving your lab tests and so on. It's exactly the same requirement for the kinds of structured information that we document and house and how we move them around. And then in addition to being, sort of better informed about the actual content of they can see in their information and the interactions that they're able to do with the PHR, the net effect of this is that patients demonstrably become more activated as patients. It's empowering, it's makes you more aware of the issues, and it gives you the ability to become more healthcare literate as well as digitally literate. So the next slide, please. So getting down and crunchy with this, we did a enterprise architecture like approach. So many of you on this call may have been involved in enterprise architecture in some way or form in your organizational strategic planning and organizational planning. But again, like I said before, we did this with the lens of the patient as enterprise. And we identified all these items that we've just been discussing. And so our objectives have been focused currently on increasing the availability and the format of the usability of the format of the information that patients are able to access through the PHR. We have many options for making care safer, more accessible, and more equitable through the PHR, especially with online booking, like I previously mentioned, that you can do with your rental car. And equitable in that you can contribute socioeconomic determinants of health information. You can make sure that it's there, like you say, your language preference. And also, of course, more equitable in that you have access to the information so that you're a much more equal player in the team. The navigation is incredibly complicated, and that was pretty well, and coordination was pretty well the background to the Greg's Wings story of almost total failure of that. Transitions of care between specialists and the primary care. And then also the PHR having ability to be able to provide information around tests, background information at patient level of understanding. And it can be as simple as if you have a blood test, like one of the blood tests that monitors your diabetes, with a standards-based approach with a unique code of a diabetes test, you can tap on that and pop up a patient level information around what's the purpose of that test and how is it going to be interpreted and what do you expect when you're going to talk to this with your provider. Similarly, your medical imaging report and being able to understand, okay, what's this test for and how does it work? And also even get information about a procedure, upcoming procedure, about what kind of pre-procedure things that you might expect to have to engage in. So those are our sort of function and content kind of objectives. But overlaying all of this is, as has been alluded to several times earlier already in this conversation, about provider engagement and patient engagement. So as Nicole was saying, providers are frightened by and large by the notion of patients suddenly being able to message with them or being able to see their blood tests. I've heard some people saying, and in fact, a digital imaging director, physician director, was convinced that having access to imaging tests was going to result in suicides. And she provided some anecdotal reports in the literature about suicide following learning about something in your medical imaging report, which, by the way, has been debunked over and over again in a peer-reviewed kind of a way. And similarly, patients not really all being aware of what the opportunities are, and many having barriers which they think will preclude them from being able to do this. And some of those are real, and some of those we're trying to work on, right? But so we have a real job to do, that we can build the most perfect function and content, but we need to make sure that people trust that this will work, that will be helpful, that there won't be adverse events, that their workflow won't be more complicated, their administrative burden going through the roof. And in fact, we're intentionally looking at it to ensure that administrative burden substantially is reduced. And in the next slide, please. So I won't go into all the detail around this, but you can read it later if you like, because I think most of it's been said. But really, we're talking about enabling more information, better access, better workflow, and improved digital and health literacy. And there's so many different examples about being able, first of all, like I was saying before, with the integration, not having multiple logins and going to multiple places. You can get your results and trend them over time and get your care plan and clinical summaries, which you can have your eyes on to help assist your provider to ensure it's complete. Having access from proxy access for elderly family members. I personally had to go through this now twice with my wife's family and my family, and it's terrible when you're at a distance and you're trying to help your parent navigate the system. The phone tag, and Bridget has a background of managing an office and knows full well this phone tag and listening to answering machines and missed appointments and stuff that happens because patients you can't do asynchronous communication. And those practices that currently do asynchronous communication through texting ends up having all that information is outside the record. It's in your telephone company's messaging thing on your device. And that is actually quite dangerous. Some physicians who've done this through special kind of online ways of doing asynchronous communication, but it's still isolated from the chart, actually take the time to copy paste their threads and put it in the chart, which is very time consuming. What we're talking about is having all of that seamless and automated. Getting recall notifications from the office, I can tell you from my own practice experience back in the days when a stamp was 14 cents, was still really complicated. Getting letters out to everybody to say, hey, you need your mammogram, your whatever, your diabetes, you haven't been in for 9 months now, we really need to see you. Those kind of reminders that are kind of routine are hard to execute. Even flu shot. I'm sure, Nicole, you remember those lists that everybody had on paper for everybody over 65 who needed a flu shot, and the MOA went and ticked them off as he did them, right? Well, that's gone when you have both an EMR and a PHR working together. And it's hard to underestimate what improved literacy means to patients in terms of confidence and adherence. We don't use the term compliance anymore. That's thrown out because really compliance means that patients are, they're just bad patients, as opposed to adherence means that they don't know what's going on. They don't understand, or they don't get the importance of it. And so what we're trying to do is improve that literacy to address those kinds of issues. So anyway, that's I think that's all. I'm going to pass it. I guess I'm going to pass it to myself. No,
I got one more slide for you, Bill. I pulled a fast one on you.
You should. Okay, whoa.
Don't turn your back on those newfies, I'm telling you.
Yeah, that's right. So I think we've already covered much of this. The standards and usability piece, though, which is near and dear to my heart, is key. Is foundational in this. We are continuing as a country, and definitely as a province over on this side of the country, thrashing around with this. And my hope is that the issues that we're raising will help put a lens on what is needed for interoperability of all sorts, so that a order is a service request in general. That the state machine, as it's called in informatics world or in data science, of an order, which means who's responsible for making the appointment. Has the patient been contacted? Does the patient know about what the time of the visit is? Does the specialist need more information before the patient can be seen? What needs to be done before the appointment? What are the rate limiting steps? All that stuff is on the table for what we're talking about, and that's needed and embedded across the system. And the PHR is that gold in the fragmented pieces of everything that we've been talking, that puts it together into a meaningful and usable whole. And then the next slide, please. This is an adventure. And this is over to Bridget.
I'm going to ask Anton here to just recap a little bit on the projects on flight globally and that we've seen around the globe, and some of the evidence and research and hesitations that we've seen and successes. And then he's also going to speak to some of the relationships we've been building, because that's a lot of the work he's done. So.
Thank you, Bridget. So as I reflect on what I'm hearing Bill and Bridget and Nicole is telling us, and what we've discovered so far, I'm going to try to put it all together for us, and probably will deal to a great extent with slide 12 and slide 14. And then Bridget will tell you the practical story of how did we arrive where we are, and what has been happening in the background. While I do that, maybe Ray, if you feel comfortable at the end of Bridget's next piece, if you want to share something and reflect on what we share, this might be an opportunity for you to consider that. But so we have this important opportunity in front of us. This opportunity was assessed very thoroughly through benchmarking environmental scans in the country of Canada and across the globe. And we've discovered that in places where this was tried before, more than 90% of the cases, it failed miserably. There are specific reasons why this failed. We had then the fortune and the blessing to be able to understand why and what the reasons were where this might have failed. Even if in our own country, a beautiful project in Nova Scotia at multi-millions of dollars did not succeed. What we now know is when we ask our patients and our family to tell us what is important for them in regards to having their own information available, we begin to hear a story that a patient sitting in Timbuktu, in Tache, in Tekla Landing, very far away in rural environments, there are 240 places in this province excluding our far reaching indigenous communities that sit with challenges. As those patients flutter on their way through the most or the nearest community, in the case of Takla Landing, 4 hours drive with a vehicle before you might reach Fort St. James. And you seek your care there situationally or by an emergency. You are being referred further to Prince George, or you visit extended family and you go down to Vancouver and you seek your care in the world of more than a million patients being unattached in the walking streets of Hastings. There is this absolute risk to safety and breach of securities. So imagine for yourself, if we can have a system that is reliable, that is truly integrated in the deepest meaning and sense of the word, connected from the highest level of the system, where you can access your information through a third-party authentication, and you can go into the portal that's called the digital health system in the province, the gateway system or Care Connect. And you can see your information. You can tie that into your patient medical home and have a bidirectional communication when you identify that your problem list is not updated. And you can send a message to an MOA that can acknowledge that. You can receive a message that you have a pending appointment, or you have a recall that says you should go for your pap smear test, or you see a urologist and you can complete a pre-visit questionnaire that gives the urologist accurate, current, actual information. And when you go see the specialist on a designed, scheduled appointment, or you are transient on your journey and seek healthcare episodically, whether you are attached or unattached, the provider that you see in an emergency room, in a walk-in clinic, in a specialist office, will have the most updated care plan, have access to that, will see your updated medication list, will see the allergy list that is there, that is updated. Can you imagine if we can have such a system? So, in our process and our journey to build relationships and trust, we are sitting next to the government, and as we speak, we are building a project with SMART goals, capital SMART, that builds this third-party authentication, that builds the proxy access, that builds the accurate display of your care plan and your patient summary, that creates the chance that you can have recalls and that we can build forms. And if we can build one, we can build all of them. That's the story that we are humbly telling you here. We are not dreaming this pie in the sky anymore. We are walking this walk in a tangible, concrete, incremental, stepwise approach. The patients and the families are with us along this journey. And here is an incredible opportunity. So what we have done is more than talk. It is now getting to the tangibles. And I will allow Bridget to share a little bit of that. And then Bridget, you might hand over to Ray if that is reasonable for him, and he can close this piece off if that is okay. Bridget?
Thank you, Anton. And I believe, Sarah, you circulated our 4-page one-pager that has the research and the tables, some evidence, and the projects that were in flight that Anton and Bill spoke to as well. So you're more than welcome to follow up with us or check that handout out as well. And I'm a little disappointed that Dr. Clifford didn't talk about polyportalitis, because I love trying to say that word, and what we also call portal soup. We don't want to be another portal soup, and we don't want to contribute to that, to more siloed data. So we've been trying really hard to build relationships, to build those tunnels, to connect so that every door is the right door for the patients, those that have a portal, those that have a PHR, so that we increase the amount of data available. So really, when we're talking about building those tunnels, we're talking about what Bill said about the integrator. We want to contribute as well. So we can help bring some of that information together. So we've been working with our partners, which was on the second slide, the Ministry of Health, PHSA, Northern Health, Doctors of BC, First Nations Health, Health Quality BC. We've been working on all these partners and figuring out how we can leverage this at the provincial level, even though we're a small rural project. So we can contribute to some of the data as well. So that's, and then we're also working with the Health Gateway teams. So that's a great thing that we're working for, especially single sign-on and moving the care plans back and forth between themselves and ourselves. So I think we're down on slide, Sarah, slide 11. So yeah, just stay there for, go back one for a minute. Ray, did you want to speak to our relationships with the ministry and PHSA before we go to the next slide? I'm just going to give a very brief update on our current state on the next slide, and then we're going to sum up.
Yeah, sure. I hadn't really prepped for that, but let me know if you're having problems with bandwidth, if you're not hearing me. But this project has kind of really been aligned within the provincial data strategy over the last few years, and has kind of flowed out of a rural partnership work that this group is a part of. So the linked sectors actually feeds into kind of all of those rural partnership tables, from the provincial table to the virtual health and wellness piece. And this is another piece of work that kind of feeds out of that. So ongoing work, not looking at a personal health record, like a proprietary thing or anything like that. It's kind of platform agnostic. At the end of the day, it's kind of much more about the principle and proof of concept in a way that works for rural. And I will just hand back to you, Bridget.
Thank you. Thank you for ad-libbing as well. You guys are great. Okay, Nicole, can you do an interpretive dance? No, I'm kidding.
No.
Okay, next slide. And then we're going to wrap up. So as Ray mentioned, this isn't about trying to pick a winner or building a PHR. We're trying to create a movement. We're trying to create some change. We're trying to have people to start to think about the patients in a different way. So we are vendor agnostic. We're a shameless bunch. We'll work with anybody, but right now we're only working with one vendor currently that is able, has a PHR that is connected to an EMR that's not just connected in a way that's proprietary, but they can actually move information around. So, that's a great win for us to have somebody to work with to be able to tease this out. And we are starting in rural areas. We need to start somewhere. Patients in rural areas do have a lot of challenges and transitions in care. There are a lot of geography between us. Sometimes our doctors, family practice, and our specialists. And there's a lot of places where the data and the information doesn't flow, as Nicole mentioned. So when we started this in 2020, we only had 12 providers signed up with us to try out this. We now have almost 200, but we're still very early days. We just got some functionality. We've been doing some design thinking. If you've ever looked at anything like that, we can give you some links. But basically looking through the process of what is it the patient needs and the providers working together as a team and trying to iterate basically what that design would look like. So that's where we are right now. We can come back with an update, maybe next year or when we do have some more, but we are really, really thankful to have at least one vendor to work with. And then we're going to move it over to the last slide. Okay, so 14, sorry. So we're just going to summarize a little bit. Anton, do you want to try this again of bringing us home?
So we've told you the story that patients have a problem of not having access to their data. When we talk about data, we talk about an holistic lens around data. We talk about a learning health system. We talk about, even, and now I'll throw in something that's a teaser. Can you imagine that we can use AI effectively through voice recognition and transcription in the conversation that you have or the consultation you have with your physician or your service provider, and it converts into a conversation that is transcribed accurately into the medical record? Can you imagine that we can use that data effectively in a learning health system environment to understand disease better, the limitations on your care plan, and how it can be improved? If we can integrate that into your longitudinal patient record, the place that Barbara Starfield told us, as I shared from the beginning, that is unconditional in its output to improve your health, save your life, change the outcome, and ultimately address disparity among disadvantaged populations. Imagine if we can send you reminders, and if we can make sure that there are forms to be completed post encounter and pre-encounter to help make sure that we capture information accurately and plan your care even better than there is. Imagine that we can help the MOA to save her time, to be able to do better patient care instead of running around and trying to coordinate all these legio stuff that Bill has spoken about, where we make mistakes because we are human and our manual systems and the fact that we still use the archaic fax system in this province, in the country, is something that we can definitely do better. That's our story. We are grateful for you to be a witness to how this unfolds in front of us. We are hungry to hear your opinion and to hear your suggestions. And over to you, Sarah, and your team to ask questions and see if we might be able to answer. Thank you for your time to listening to our story.
We put some
Wonderful.
examples here, but you any questions, anything, this is just to get people thinking, so.
Yes, excellent. Thank you. So there were some comments in the chat that people weighed in. And if anyone that started off weighing in the chat would like to speak to their comment verbally, happy to. I'm going to have Kathleen is going to lead the Q&A, and you can raise your hand or jump in, and it's we'll all go from there.
Okay. All right. Well, thank you so much for that amazing and informative presentation. Mind is racing. I think I knew a lot of that. I don't know that I knew all of that. So I'm grateful for the depth and breadth of that discussion. As far as I just want to maybe turn it to the folks in the chat, if they wouldn't mind, anybody wanted to jump in and expand on any of the comments that you had in the chat before we get to some of the questions that are out there.
I wouldn't. I thought that maybe I was a little bit opaque with that comment around Nova Scotia, following up on the comment there on its failure. Tethered means the other approach of having a PHR that's really a portal associated with a particular chart. So it feels like it's a personal health record in your hand, but it's really tightly tethered. And if there's one thing that the research has shown, is that approach is doomed to failure. Other approaches, there's evidence that it's successful, and the farther away you get from tethering, there's all these different kinds of options of the configuration about how a PHR or a patient record fits in. But the tethered is the worst. The other thing to follow up on some of the other comments as well about our standards-based approach and vendor agnostic approach is that our goal is, and interestingly, the one and only vendor that we're working with at the moment is totally behind this, that if we're successful, any vendor who chooses to enter into this space is at an equal footing. They just have to adhere to the standards-based approach so that they can pull data from the various places, and then they put it together with their magic sauce for usability. But their experience shows that when you do it this way, that the vendor market tends to get to a certain stable level, and it's not a huge number. But nobody needs to be frightened that that will bring an avalanche of different participants. And just by way of making that real, Apple Health Kit follows pretty well exactly the model that we're aspiring to. And the US Office of the National Coordinator has been working diligently. I've been following in my previous role as CMIO to all the HIMSS conferences and so on, and talking with these guys in the ONC. They've been 15 years it's taken them to get to where they are now, but to a place where 95% of the vendors adhere to the guidelines. Some of our systems in Canada originate in the US and actually have the functionality that's needed to be able to pull this information and aggregate it within the PHR. And so our goal is to make that actually happen.
Thank you. Is there anybody else that comments from the chat? I think that might, I'm looking at it quickly. I think it might have covered them, but I just want to give everybody an opportunity before we move in. Okay. I've got one question just quickly, and again, this doesn't need a gigantic answer. I think at this point, I'm very happy to see, patient and family voices and how those are being inserted into the strategy and projects, and the thinking every step of the way. Do you have a little bit of information for us on how that's happened? I know that, having worked in the system for a really long time, historically there's lots of tokenism. We have a room full of people and we take a patient and we put them in that room and then we check the box that the patients have been included in that discussion. And I think for truly to have something that's impactful and effective, it needs to work for the patients. And so I'm just interested at all in a couple of lines of thinking about how we're including patients, and particularly even rural patients, into the strategy and the design for the thinking.
Kathleen, I will reflect to Bridget, but can share with you that that RCCBC stands for a pentagram partnership relationship-based approach. This network believes in its heart that it is stronger because of us and not of me. And part of the us is the patient. That is absolutely the most fundamental part of this journey. And for us, when we talk about patient, we talk about patient and family. So we have the luxury within RCCBC to have access to patient focus groups. And we do have a specific group that is assisting us to help tell the story. Maybe that is something that Bridget can share with you. This patient focus group elected by themselves, without our guidance, to first tell the story to patients like them. And we have a beautiful video that they developed in a Dan Pink style that is short, and we can share that link with you. It's actually cool. You can even watch it while we still have this conversation, where patients tell each other about the importance that your health record is important to share the story. Then beyond that, we do engage at a larger level through Health Quality Council, through their Patient Voices Network with patients, and understand a little bit. So that's something that I want to share with you beyond the design lab that Bridget will now tell you as we go into a community such as Valemont. What does that look like in practice, to give you a flavor? Ray, over to you.
Thanks, Adam.
No, I was just going to invite Bridget or Nicole to speak to the design lab process as well, which was kind of really quite a granular thing. So
yeah, Nicole, I was going to get you to speak to that, like how we did that in Valemont, because that was lovely to have those patient voices right at the table.
Yeah, I think it was, we got the BC Patient Quality Council, I'm sorry, their new name, just to help us with that. It was we make a lot of assumptions in this. So it was one of those things that it got rid of a lot of those assumptions and found we were wrong. So we put patients, providers, and we basically took stories from patients in Valemont, and we drew a journey map of their story and their experience in healthcare, in the health system. And then we did the same for providers. And then we put everybody together in a room and chatted around those challenges and ideas and what could make it better, what was most important, what were the priorities. And from that, it was a really powerful experience, I think, for all of us in the room.
Fantastic. Thank you for that. And then I think maybe is there some place that I can follow up? Would it be best to follow up with Nicole or Bridget? I just wanted a little bit more information about that, just to make sure that I have a really full understanding, and I don't want to take up all the time in this Q&A for this.
Kathleen, you can reach out to me. I would be happy to put
Thanks. All right, appreciate that. Okay, turning it up to the group. Any questions for our presenters?
I have a question.
Please, Jane, go ahead.
And my question, I'm always interested in, patient input to things. And I'm always interested in what is the demography of the group of patients you're working with. And I ask this question because I'm a queer senior. I work a lot with queer trans, with Indigenous, with First Nations, with a very, very wide group of marginalized folks. And I always worry about, are those people amongst the patients that we're talking to?
Actually, I put a note in the chat there to answer the question. And the ironic thing is that we're weighted too much to the older age.
That's what I was worried about. Hey,
exactly. Guess who's got the pointy end of the stick at them, right? So I think the one thing that is apparent through the literature and through our own experience is that age is not a surrogate measure for digital illiteracy. It's actually can be the opposite. In fact, some of my older physician colleagues are the ones most engaged in using an EMR effectively for quality improvement. So the gap really from many angles is that middle to younger age. But the good news there is that they're less likely, but not immune from, complex conditions, and even a desire to have that integrated view given the state of their record. They may be more interested in the portal view, which is a good thing to hear as well, but also speaks to our approach is to not stamp out portals for that and many other reasons. And the Health Gateway is a great example that Anton lingered on a bit on our work. It's awesome to have a central repository of some stuff, but it can't be the central repository of everything. Because there's so much micro services going on that it's totally inefficient as well as almost impractical to do that whole state machine of, say, a service request process by going through a middleman somewhere instead of just going direct. So, so anyway, yeah. So I think the younger group we need to deal with a little bit more. The older group seems to be extremely well covered.
That's great news. Good.
And I add to it too, because I can put on my older hat.
Yeah, right. Well, we won't go down that path, will we? You know.
Allison, you've got a question. Oh, you're on mute still, Allison.
You're still on mute.
Oh.
Now I'm good. It's the old microphone trick. Perhaps this question is for Bridget. How far off are we from having some kind of integrated personal health record? You know, not all pieces are obviously going to be able to come on board. You know, one of the questions that was posed at the end there was just your own experience with it, and it's just. It is mind-blowing that you can get your own lab results. And it was just even checking my own 14-year-old's lab results who didn't come in abnormal, but her iron was on the low end. So it didn't notify anybody to like look at it. And then when you look at it, you're like, oh, okay, that, you know, it is on the low end. And just how empowering that little piece of information is. And it's a very, very small issue, but just as a parent, I just wanted to add that my own personal experience with it, and just it's great to be able to have something at your fingertips. So just how far are we from having something like this in somewhere?
You're on mute too.
I did the same thing. So we did have it rolled out in northern BC. So there's about 200 providers, about 5,000 patients currently using where we're starting with our integrated personal health record. The personal health record is integrated with the physician's EMR and with Northern Health's data. So what we'd like to do is expand the data that's available and the functions and features that the patients are feeding back to us that they want. So we are starting, we are there. We do have a product that we can work with that is connected and integrated with an EMR. And then the next steps are integrating at the provincial level. So we're getting there, Allison. Where are you located again? You're in?
I'm in Comox, but
Yeah.
that's wonderful. I mean, all these things are not easy to do, and you know, just hearing that functionality exists and it's being piloted is awesome.
So Allison, we're neighbors. Yeah, I didn't know that. Your examples is perfect because it's a good representation of, it's already getting to be almost ubiquitously available for the purpose and use case that you just described. Because in your particular instance, and the same would be in the north, you have two options. You can go to a Life Labs and get it through the Life Labs app and still see that iron. You can go to the Health Authority My Healthy Life, which is exactly the same portal, different content, but different as in the north, and see it that way too. And for at that particular age and stage, and I don't know all the details behind that, but generally that's sufficient. It's the more complex cases that are, and it doesn't have to get much more to be meaningfully to have that integration, and that's that extra bit. So we do have a solid base, and unfortunately that's a bit of our Achilles heel, because many people are saying, well, it's done, but then enter stage left, polyportalitis, stage right, portal soup, and frustration, and multiple logins, and lack of ability to integrate. And that's what we're about. We're trying to take it to the final mile.
That's great. Sounds like the issue is being framed really well. I'm going to go to Lorraine, and then I also see a bit of a dialogue happening between Anton and Naomi in the chat. So Lorraine, you've got a question.
Yeah, I wanted to talk a little bit about connectivity as well. So we have unstable internet connections consistently, and just people's inability to, or their lack of skills in order to access this type of information. And then the third thing that came to my mind as I was listening today is security. I'm sure you have all the things that you need, being not a major computer person, but there's security issues. You hear about this hospital shut down, they can't do anything because they're being held for ransom. All of that information is out in the community, and how do we combat that, or what can we put in play to address those issues? So connectivity, security, and then just the general public's ability to access the information.
Dr. Clifford, do you want to take
Yeah,
that one?
I'll take a stab at that. Certainly the security part is the easiest, albeit the most dangerous, right? But it's such on top of mind that you could argue that the extra diversity that a PHR and having access in patients' hands through a independent PHR vendor is a safety valve for those circumstances where places get shut down because they have no access to their information. Well, the patient has access to their information, which then translates to when they're in Mexico, Kathleen, show up, and just hold up or give a PIN number so that the person can actually access it on their own computer. You've got more portability of your information, and this is all done to best practices with standards. And so that part is the least of concerns, but certainly to be fair and equitable, we have to be mindful of people with limited experiences with digital solutions. So that needs to be a part, and is a part of our work about usability, about support by others, because sometimes the person who's going to really benefit from a PHR isn't using it at all. Right. It's their family in Nova Scotia that's, I'm just trying to find another place that's far away that's not here, is able to, by proxy access and secure proxy access with their own ID. So a current barrier right now to using the Island Health, for example, and the Northern Health PHR is that you have to be a patient in Northern Health to be able to get the proxy access, whereas a PHR offers the ability to be entirely independent, and it's based upon, and the same with children, so at both ends of life, right? So which is where it's going to actually maybe be even harder to be a patient at the same time as being a proxy. So that's a real concern. In terms of the digital highway, we certainly are miles ahead of what we used to be, and the North, to some degree, enjoys maybe less than you'd think, and that was due to a primary care transition fund projects that we did in the North to bring fiber optics into so many different areas. That's not saying it's everywhere, but it's not as bad as one might think. But we still have to address the issues in those really remote areas, and that it can be achieved again by personal health record because it's portable And the current system that we're working with is still online only, but it's not a big stretch to be able to download that in a secure way into an encrypted, and I've actually experimented with this before and it worked, into a personal health record on your device, and then you're off and just completely disconnected. And when you take it to a real fancy extreme, when you get reconnected and you had entered stuff in, it automatically syncs. People who do bridge inspections, I worked with a guy who wrote software for bridge inspections for many years, and he says that's a piece of cake. I used to do my stuff sitting under the bridge in the pouring rain and doing it all, and when I got to a modem in the hotel, man, it's all back at head office.
My banking app works like that. I can see all my balances until I sync back in the next time to get the deeds. So I see Anton's got his hand up, and then Tony.
Yep.
So in this era ahead of us, I read it as being the era of morality. In the first block of our explosion around health and healthcare, we had the era of science. We developed penicillin, we developed insulin. We then went into an era of so-called quality improvement, best practice, evidence, learning health system. Those things will stay with us. We will not let go of the science. We will not let go of the quality improvement, and the best practice focuses lean management systems, trying to save cost. For me, the era in front of us is being pro-poor and pro-vulnerable. And we drive innovation from the edge within the rural environment. Way more than anyone else can drive it. As Bridget said before, if it can work in rural, it will work somewhere else. So in this era, when you do a satellite map of the 240 little small rural places out of mainstream in this province, within 1 kilometer, you drop down to 6 megahertz in terms of your signal strength. And that cannot carry a visual picture, or sometimes even not a sound relay. It will not be what this group of individuals around the PHR project is trying to do. When you sit with this horsepower and you have a Bill Clifford that has received the Order of Canada, and you have Nicole Ebert that is the face of a family physician in the country of Canada par excellence. When you throw my little knowledge of system network involvement in, and Bridget's coordination and technical expertise and interconnectedness within the network, and Ray Markham that is so gracious with his time to allow us just to push our way open into the new environment around us. We can move nowhere if patients like you are a patient as well. If link sector like you, that's a voter, goes and tell a government, it is time to fix connectivity. It is time to change from looking at the social determinants of health and change that into a social determinant of trust, which in my world might be the most important social determinant in the era ahead of us. If we don't create alliance and coordination and collaboration in conversations like this, and actively go form a journey that will knock on the door of a politician and change the hearts and minds of how we spend money, either from private sector side and or a government, we will have this conversation a generation from now. That's my plea, and that's the urgency, the intimacy, and the importance of a conversation with you like today. I hope that makes sense, and if I can place a weight on your soul when you leave this room today, is the understanding that this is not a chit-chat anymore. This is about survival. This is about metacognition, the thinking about thinking to position ourselves in the most strategic manner to be successful in something that will change lives forever if we do it right. I'll pause and hold. Tony, curious to hear your thoughts.
Thanks, Anton.
Well, first of all, Anton, thanks very much for making me follow that. I do have a weight on my soul now. I do agree with you that morality needs to come back, and great choice of words there. My question came from the patient's perspective. Some of you know my background, Anton. I shared it with you and some of the others on the initial call when I joined this group previously. I'm the child of a rural family practitioner. I've lived this all my life, certainly not as intimately as many of you. But there's a mysticism associated with medicine, and there's a real lack of understanding. I mean, I speak to my friends and family and people I interact with daily about medicine and the medical language, and I'm wondering if during your patient focus groups, did patients express concerns or a reluctance to participate in what you're describing? And if so, how do we overcome those concerns and their reluctance? So I'm just going to hand that back, and this is my question. If anyone can help me, that'd be great.
Yeah, the reluctance to participate, of course, would be expected to some, because not everybody is of this in healthcare. Some people just want to hand over, to the provider. They just have sometimes a misguided trust that the system's going to work. I spend much of my time with friends and family, cajoling them to say, you haven't heard yet about that visit you had with the oncologist. Maybe you should, or you're supposed to have, I should say. Maybe you should phone. And in one case, that they did, and it was lost, just like Greg's wings. So, yeah. So there's a lot of people who aren't fully aware, and so this is a journey. As I think all of us have mentioned, we're not there yet, both with provider and patient engagement with what's going on here. But we're making steps ahead, and I think as other people start to see the successes of their friends and neighbors, their family, and maybe even themselves as they dip their toe in, we'll just start to see this moving ahead, just like cell phones didn't take too long to get in everybody's hands. And I don't think if we get a fully interoperable system, it'll take that long to get a personal health record to some degree in everybody's hands.
Okay. Thank you, Bill. Now we've got about a minute left. I've got two quick comments. Tony, did you want to jump in with something real quick? And then Pabella.
Just the last thought that occurred to me, Bill, following on what you've just said, was advocacy. And I know in my own personal experience, and many of my friends, and an actual individual who I know who did this role in Winnipeg, she became a patient advocate. She'd been a social worker in the hospital, and she moved out of the hospital to become an advocate because the people she spoke with on a daily basis had no clue what was going on around them. They were totally lost. So I see this IPHR, and again, I'm new to this, and this may all have been done, and you may have worked it all out, but so you hand a patient a tool and they're just no more engaged because they don't understand what they're doing. They don't understand the space they're working in. It's a mystery. So I'm wondering how you've thought about addressing that. Not everyone has this depth of knowledge and this clarity, or semi-clarity regarding the system. So I am wondering how that will be addressed.
Yeah, but all really good points. But having eyes on the various stages of things is super helpful, so that that, say, for example, that somebody's actually received a referral on your behalf and you have some idea about what its contents are is huge. But I would argue that advocacy is the wrong word in this place. It's commonly used. Don't get me wrong. But when you think of advocacy, you're thinking that generally refers to a person who's maybe downtrodden, disadvantaged to some degree, and you're trying to advocate to make something happen. Really, most of what we're talking about here is catching a bad system. So you're helping people navigate that which they have challenges in navigating, and they don't have the tools, the assistance, and they're definitely missing the information. So even somebody who can help them navigate, they can't hand their phone to somebody and say, what does this mean? Because they're just stay in the dark and there's nobody to help them. It's impossible to help them, even if you're medical. So I think that's where we're going with this. We're trying to fill the gaps today in the health system. And just one last comment about it. The exposure of notes to patients has been shown to improve the quality of notes and to improve the actual harmful behaviors that go on. There's actually evidence that the language that providers use in their notes prejudice care for people coming in.
Yeah.
Referring to the patient as being non-compliant and all these kinds of terms. You go into Emerge, somebody reads that, they pay less attention to you. So what we're trying to do is strip that away and expose those kinds of things. And one last thing is, oh, don't get me going because it's just so much cool stuff. So it's even got forensic capabilities. There's a case in the UK that was shown that a patient would not have been murdered by the provider had there been more eyes on what was going on in the notes by that provider about that patient.
So Kathleen, before you sign off, I would remiss if I do not try to give us a tangible outcome of this meeting.
I appreciate
Concrete
next step. Yes, thank you.
So, your horsepower is incredible. In your organization, the people that stares back at us on these Hollywood screens, it is a phenomenal opportunity for us. How great would it be if you go reflect on this conversation and Sarah, maybe coordinate a letter to the Minister of Health, copy Stephen Brown as the administrative agent of the bureaucracy, and tell them how important an engagement like this could be and your learnings. And Bridget and us can help shape that message if you want to. But can you imagine if you begin to tell the story, this is what private sector or the link sector stands for, and would like to encourage co-development of something that is more meaningful. That's a tangible how you can help us. How we can help you, you need to come back to us and tell us what's important. Not just our story of what we do, but are there things that you want us to focus on? We are open and will embrace that opportunity. Kathleen, I just wanted to take what you facilitated and put it into tangible next steps, perhaps. I wonder how that lands.
Yeah, I think that lands very well, I think, as far as the next steps. And clearly there has to be next steps. I mean, it's such a passionate group and a fantastic subject. And I don't think we're done yet with this conversation. So I think, Sarah, we'll take that offline and see what else we need to organize or facilitate, because I do think the richness of this conversation will help contribute to how we use the power of this group to create some outcomes. Excellent.
Yes, thank you. This has been so excellent. I don't want to parrot what everyone else has said, but the engagement and the passion that is here in this room needs to be carried forth. And that's what we will do with this. Share it wide. The letter to Stephen Brown can be written, and I'll put it through your eyes so that we're capturing it correctly. I'd love to be able to pass the draft past you, Anton and Bridget and Nicole and Bill as well. Like, if you guys want to help craft that letter, we would love to send that and make traction on this. With that said, we've gone 5 minutes over, which isn't terrible when there's passion projects. It's good. And thank you so much, everyone. We'll follow up with the email as to our next topic, unless someone wants to shout it out right now, what we should do with our next meeting. Otherwise, we'll do a quick email around of emails to see what our next link sectors topic should be on, unless we continue down this path until we have solution.
Is there something we could talk about? And I mentioned it in the chat just quick, and this is a huge issue for our community, is something around what we can do to address staffing issues and hospital closures. I don't know if anybody watched Global News, but Chetwynd was finally on the news regarding our closures. And literally our hospital has been closed more than it's been open this year already, which means closed. Like, doors are locked, sorry. Hope it's nothing serious, but you got to drive to Dawson Creek an hour and a half, or Fort St. John, or Prince George. So I know my members have reached out to me to kind of figure out what we can do, or what our steps are or how we could help. So I don't know if there's something that we could touch on as this group, or just toss some ideas around, or somebody send me some emails. That would be awesome too.
Okay, awesome. Thanks, Naomi. All right, everyone. With that said, I'll let Kathleen get back into the sun and us go out and shovel. Too bad we're not shoveling sun. It is what it is. And enjoy. Happy New Year. Thank you so much and for this meeting. And one last thing I'll say before, I know I've already said I'm going to let you go, but if I recap some of the words that everyone shared at the start, and then if with what happened in this meeting, the presentation, it all was so intertwined. We had exploration, compassion, balance, gratitude, feral, curiosity, change, strength, trust, all of the words of this group today led into what this presentation was. And I think carrying that forward is really going to evoke change, and I love it. So thank you again. I'm so happy to be a part of this.
Thank you. Thank you,
Thank you
everyone.
very much.
Yes.
Cheers.